All right, it is 8 a.m. in Boston, and we have everybody ready. So we're really excited about this one. Welcome to our third in the series in the global spine surgery. Today we're discussing how to interpret advanced imaging in acute spine trauma. Here's the course agenda. Just a reminder, today we're looking at the advanced imaging and acute spine trauma. Next week, we'll be looking at adolescent idiopathic scoliosis as our last case discussion. And then a reminder that on the 31st, which is a Sunday, which is a departure from our usual Saturday, we'll be looking at endoscopic spine surgery. So make sure to tune in to both of the next subsequent weekends for these. Just a quick logistical reminder on using Zoom. You can turn on the captions. Feel free to join the conversations, and we encourage questions. Please raise your hand, use the raise hand function, and then also feel free to post your questions in the chat. We'll monitor those and try to address them as the course goes on today. Another reminder here for the Sona Global Academy, where you can find all of the modules, especially in upcoming sessions. Like, for instance, today's were posted. There was some educational things you could have got for to prepare for today's courses, but there's lots more to gain from that. So we encourage you to go check it out. Here's an example on complex lower extremity trauma. There's a lot there to learn, so please go there. Course objectives for today are posted here, but essentially all um, come together to understand interpreting advanced imaging um, in spine in the acute spine trauma setting. And then you're introducing everybody. Dr. Karen Agarwal Harding is the course chair and director of the Harvard Global Orthopedic um, Collaborative. And then myself, I'm Peter Nahurukame. I'm one of the orthopedic surgery residents here at the Harvard Ortho Residency Program in Boston, Massachusetts. Here are the HGOC and SONA organizing team. Lovely, very well motivated, and awesome team without who any of this would be possible. Quite large team, quite very, very helpful. So very many thanks to them. And then our faculty presenters today. I have the privilege of introducing two uh, outstanding radiologists, musculoskeletal radiologists from Massachusetts General Hospital. I have Dr. Connie Chang and her colleague, Dr. Jad Husseini. And then joining them will be a spine surgeon from Beth Israel, deaconess in Boston as well. This is Dr. Sapan Gandhi. So should make for a great discussion. So on today's agenda, we want to stay pretty close with timing, and so this is gonna discussion will go up to ideally 8:45 Boston time. We'll have some welcome remarks, which we've already done, and then we'll jump right into the lecture and discussion from our presenting faculty, and then we'll have some closing remarks afterwards. So with that, I will invite Dr. Chang to share her slides.
Connie, you just need
Can you
to
hear
unmute.
me? Oh, okay, sorry. Sorry about that. All right. Can everybody see my slides?
Yeah, they look good.
Okay, excellent. Thanks everyone for having us this morning. We're really excited to be here and to share this with you. Actually, it's going to be kind of fun because the three of us are going to kind of go back and forth and be able to discuss some of these cases for you. So, I'm Connie. I'm a musculoskeletal radiologist, which means I look at bones and joints all day. And I'm going to start off talking about CT. CT, sorry about this slowly blurry image. I'm going to talk a little bit about technique and sort of the spine trauma protocol. Of course, we acquire everything in axials first. Nowadays, depending on what you have locally, sometimes it's no longer done usually single slice anymore. It's either done helically or even sort of big 3D acquisitions. And then these are constructed coronally and sagittally. And then we also do bone and soft tissue reconstructions. So I want to talk a little bit about those bone and soft tissue reconstructions. That's also called convolutional algorithms or the kernel. Those are slightly, actually, I'm going to minimize this so that that's not in the way. But so, you know, windowing is kind of what you control when you're looking at the image. The convolutional algorithm or kernel is what is done at the scanner with a bunch of complicated math. It really doesn't matter what is done. But the point is that they can send you the images. The same one acquisition can be sent to you in different ways. For trauma, the two main thing, and actually CT in general or MSK CT in general, they do two main reconstructions. One is in a bone kernel, and one is in a soft tissue kernel. And generally, we look at the bones on the bone kernel and the soft tissue on the soft tissue kernel. Now, what's the difference? Well, in the bone kernel, they give you really high spatial resolution. Basically, the way they reconstruct it, they give you as much detail as possible. So if you look at this bone window with a bone kernel, everything is very, very sharp. And especially if you look at the trabecular bone inside the vertebral bodies, you can almost see the little, cross hatchings and the detail. And it's very good. This reconstruction and this window is very good for those high density structures. And on the soft tissues kernel, instead, they kind of smooth over those details, but they give you better soft tissue contrast. So even though this window is different, you can see how you can see that contrast between the CSF and the brain much better here on the soft tissue kernel compared with the bone. But you're not going to see the detail. And again, this is some of this window, but you're not going to see in general, the image looks less sharp because the focus is again getting the soft tissue contrast rather than the bone, the detail, the spatial contrast or the spatial resolution. Sorry. So this is better for soft tissues, but it may blur non-displaced fractures. And you may be asking, well, can't I look at the soft tissues in the bone kernel or the bone window on the soft tissue kernel? You could, but here's an example of looking at the soft tissue windows in the bone kernel. You can see here, just looking at the brain and the surrounding soft tissues, there's a lot more of this. It almost looks like a snowstorm or a speckle superimposed on top of the image. That's all noise. And when you have a lot of noise, it makes it more difficult to detect low contrast findings. So if you have a small something, a small hematoma, a small something, it could kind of just get smudged in the background. You don't see the detail as well. And on the opposite end, if you looked at the bone windows on the soft tissue on the soft tissue kernel using the bone windows, some of those non-displaced fractures you may not see well because they're kind of blurred out. So anyway, just so you know, when you get those two sets of images, this is sort of the purpose. And you want to look at the soft tissues on the soft tissue kernel and the bones on the bone kernel. All right, and then the big other thing is that often you'll get kind of two different slices. Again, it's one acquisition, and then you can slice it in sort of different thicknesses, reconstruct it so that they send the images either in a very thin stack or in a very thick stack. And you might think, oh yeah, well, thin is usually better, right? So let's go for the thin. But there are some disadvantages to the thin as well. There's more noise. You can see again, there's more of that speckly pattern here on the thin slice images compared to the thick. And it's also a lot more images. It's much more painful to scroll through 300 plus images. And so there's a resulting more false positives and false negatives. So in general, I actually like starting with the thick slices and then use the thins for problem solving. So if I'm not sure if something's a real finding, like is this a fracture or is it just a vascular channel? Can use the thins to problem solve, or say on the soft tissue windows, I see there's a hematoma, but I don't see a fracture. On the thick slices, I can go over to the thin slices and kind of make sure I'm not missing a non-displaced fracture. All right, so what's my search pattern? I always start with the soft tissue windows on the soft tissue windows on the soft tissue reconstruction. I look for any areas of hematoma, soft tissue swelling that might clue me in where a fracture is. Then I use you can use either the bone or the soft tissue, but I like the bone reconstruction better to look at alignment, look at the facet joints, look at, the vertebral body alignment, also on the coronal as well. You can see the facet joints very, very well. And then obviously the coronal is great for looking at C2. We'll see examples of C2 fractures as well. And then I go down the axial slices and you're looking for rings at every level. You're looking for two sets of rings. One is looking for the spinal canal to make sure that ring is complete, no fractures in that ring. And then also the individual transverse foramina, those also have to be intact. And if they are not, then you automatically go and do a CTA to look for some sort of vertebral artery injury and dissection. All right, so now is going to be your chance to look for the fracture. There's going to be a whole stack of images. I'm going to scroll through first slowly, and I'm starting to scroll now, and then you can tell me where the fracture is. And this is an 84-year-old male walking down the stairs. He struck his head on the back of a counter. Sagittal reconstructions. Don't forget to look at alignment too. And here I am going down the axials. And since this will be recorded, if you want to go back and look at the images and kind of get a scroll through, you can as well. Okay, so I'm going to now kind of look at key index images to point out the main findings. So here we're looking at the coronal. So I'm trying to show you that we're going to look for a C2 fracture. And here at the base of the odontoid, we see that there is a fracture, which is confirmed on the sagittal views. You see that fracture there right through the base of the odontoid. So that's a type 2 odontoid. We'll go through those different types in a bit. And then also you see that on a little bit more peripherally on the sagittal slices that there's subluxation of both of the joint between the lateral masses. And then you can also see as you come down, I don't know if you saw this, as you're scrolling down the axial slices, you can see that there's definitely a rotatory component too. Because, oh, sorry, so this is the orientation of C1, and this is the orientation of C2, right? So the two vertebral bodies are rotated relative to each other, so maybe there's some sort of ligamentous injury as well. All right, so a quick review of the C2 fracture types. So we have odontoid fractures of the odontoid itself, that's type 1. Type 2 is at the base, which is the one we just saw. And type 3 involves more of the vertebral body itself, so going all the way down this way. Here's another example of a 71-year-old female that slipped forward. Another example of a C2 fracture. I'm going to scroll through this, but there's also an additional fracture. Let's see if you catch it as well. So here again, we see that C2 fracture, but what's the additional fracture? Sorry, there's a little skipping there. All right, so there's both a C1 and a C2 fracture. Type 2 odontoid is as similar as the other case, but I show this case to remind you that concurrent C1 and C2 fractures are common. So if you see the C2 fracture, go back and make sure you didn't miss a C1 fracture. In addition, 10%, if they have both a C1 and C2 fracture, they also have a lower C-spine injury. So go back and look further down to make sure that you didn't miss something below. There isn't something in this particular case. And then just in general, when you see one, you got to start looking, be suspicious for more because there's a high chance you're going to have additional fractures. All right, so going back to the types of C2 fractures, there's also the Handmang's fracture, which is that traumatic spondylolisthesis through the pars, and then it's usually a combination of hyperextension and distraction. If there's a lot of if there isn't too much distraction, this can actually be treated conservatively. So here's an example here. You can see the two pars on each side are fractured. And you can see actually in this case it extends through the vertebral frame, and so a CTA was done to make sure that there wasn't vertebral artery injury. There wasn't in this case, and then you can see that there's resulting traumatic antelisthesis. So, all right, and then last we have an atypical fracture, which is sort of the trash can for everything else. And this is X-ray. It's not advanced imaging, but it happens to be one of my favorite sort of C-spine fracture X-ray findings. So. This is a 79-year-old female who was T-boned in a motor vehicle accident, which means she was going forward. She got hit on the side. And the thing to notice here, I'll give you a second to look at it. So the thing to notice here is that the C2 fracture vertebral body is wider than the bottom, right? So the spine in general, right? If you think of it as a tower, the bottom it should never get fatter above. It should always get bigger as you go down because that's a stable tower. And so in this case, the C2 is wider in AP direction dimension than the C3 below it. And this is here's the fracture here, and so there's an atypical fracture in this plane this way. And that is called the fat C2 sign or the C2 vertebral fatty fracture. By the way, this is not the same as the odontoid fracture through the body because that is in the horizontal plane. This fracture here is in the vertical plane, which is not which is an atypical fracture. All right, what type of C2 fracture is most common? Well, the answer is depends on age. So there was this study done looking at sort of younger patients and older patients, and the type one of the odontoid. This is so the type one is the orange bar here. So you can, sorry, the green bar here. So you can see it really only happens in young people, and it's very rare in general. It's generally like high speed traumas. Type 2 and 3 are more common in older, although they're sort of the most common overall. But in young people, you see there's much more even distribution between all the fracture types. Um, that's probably because the mechanism of injury is different, right? So younger people, normal bone density is generally high energy trauma. They jumped off a cliff, they fell off a ladder, something, they had a car accident, something like that. Older people, it's generally because their bones are old and they're frail, and then it's because they have osteoporosis. Interestingly, 70% of C2 fractures actually happens in older people. So if you went back and looked at all the histories that I showed, there were all old people that fell that had those C2 fractures. This stat also kind of helps to support that. You can see that the in the older group, more women have fractures, with the younger group, it's more men. And it's because, again, osteoporosis tends to disproportionately affect older women. So anyway, the point is, older people, common to have C2 fractures, and it's generally because they have frail bones. All right, and then just our C2 fractures, are they managed surgically or not? And most actually are managed conservatively. I don't know if you want to jump in, Sapan, but generally, if it's not that displaced, they can be managed conservatively.
Yeah, I think this is an area of some controversy. Like you'll see some areas, some centers that are very aggressive with odontoid fractures, and some places like ours, for example, that tend to give a lot of these fractures a chance to heal conservatively. So definitely an area of like discussion and debate, and it depends on the fracture type and the patient, but. The first and most important thing is to identify them so that you can follow them, even if you treat them conservatively. So, but yeah.
All right, cool. Thank you. All right, I'm going to pass it now to Jad.
Thanks, Connie. And hello, everyone. I want to echo what Connie said, which is to thank you for this opportunity to speak to you and to thank you in advance for your attention. Um, I'm going to talk about MR. We'll show some cases, and then I think I'll change out with the rest of the team a little bit as part of the lecture, and we'll finish it off with some more discussion of MR. This first piece will talk about the basics of MR and talk a little bit about MR of the cervical spine. We're going to kind of break it down into cervical and thoracolumbar, just because there are some anatomical and imaging considerations that are slightly different. I should point out, in our part of the world and country, we see a fair bit of trauma from people who are doing downhill skiing. I actually remember in secondary school having to get out of my chair and move to a different table to see the chalkboard because there were two people at the table in front of me who were in halos from fractures they had while they were skiing. So we do see quite a bit of that here in the northeast of the United States. Connie, can you move forward? I'm just going to shout at you if you don't mind. Thank you.
Yeah,
Thank
sure,
you.
no, please.
Perfect. So why does MRI matter? So MRI is a really good tool. It has really strengths where CT has weaknesses. MR is really helpful because of its soft tissue contrast. It has CT derives its contrast from the density of materials. MRI derives its contrast from different characteristics of materials, and so that allows us to see things like the neural elements, soft tissues, things that are essentially occult by CT. And that's particularly helpful when patients have neurological defects or when there's suspected instability. So some key indications for using MRI: when there's concern for injury to the cord, ligamentous disruption, injury to the disc itself, or a setting I think that's particularly challenging with CT, which is an epidural hematoma. Epidural hematomas can sometimes be seen, when Connie pointed out, when you nicely, aggressively window on a soft tissue kernel, but they're often totally occult by CT. And so that's a real challenge that a problem that MRI can solve. So what's the impact? That means you can really, MRI can be a very useful tool that can change surgical decision making, can determine whether there's stability of the spine. Um, and is also quite useful for distinguishing acute from chronic findings. The presence of bone marrow or soft tissue edema around a fracture that's by CT indeterminate in its chronicity can help distinguish acute from chronic. There are problems with MR. Obviously, it's a resource that's quite limited, even in resource-rich settings like our very large academic hospital in Boston. Another challenge associated with it is that the acquisition times can be quite long. That's a problem from an access perspective, and it also means that, particularly in a patient who's critically ill, and who's unable to cooperate with the exam because of the long acquisition time, the images become susceptible to motion artifact, which can render them non-diagnostic. There's a third piece here, which thanks, Connie, for moving forward. I can talk about it on this slide. A third piece that's quite important that what Connie mentioned when she was talking about the different kernels and different reconstruction techniques is that most MR or CT images are acquired as a block of data that can be reconstructed in any plane. One of the limitations of most of the MRI sequences we use is that they can only be reconstructed in the plane that they are acquired. And that has to do with with the way that MR sequences are acquired. So what it means is that the slices that you get are the slices you have to interpret. You can't really do much at the scanner. There are some 3D techniques that can be used, but they're really not used routinely in the setting of trauma. So let's talk about the normal cervical spine a little bit. So we'll break this down into the different components. Bone marrow, and we'll talk about this in the lumbar spine. Bone marrow signal is particularly important in the setting of tumor or infection, but is also of utility when looking at in the setting of trauma. The marrow in the spine should be bright on a T1 and a T2 weighted sequence. Now, it's not going to be as bright as the cerebrospinal fluid as you see on the middle and the right image, where the CSF is quite bright, but it will be brighter than the discs that are the intervertebral discs, which are typically darker in signal. I think the money sequence, the important sequence in the setting of trauma, is the STIR. In some institutions, it'll be a T2 fat saturated sequence. They are essentially interchangeable for these purposes. A STIR sequence is a fluid sequence, so the presence of fluid signal or bright signal in the disc or the vertebral body or the paraspinal tissues is indicative of hemorrhage or trauma. And so that should allow you to focus in on areas of abnormality. With regards to cortical bone, all MR signal is derived from fat or water. Cortical bone has neither. So cortical bone will be dark on all sequences. The challenge is the cortical bone is so thin. It's sometimes so thin that it can't really be resolved by MRI, which is a lower resolution technique, right? We think of MRI as being better, but fundamentally the resolution, the sizes of the pixels that we create on the image, or voxels, is actually much larger than with CT or even with X-ray. And so it's sometimes the cortical bone can be imperceptible. So you have to rely on the contour rather than actually the signal of the cortical bone in most cases. So again, to go back to that point about the marrow signal, you're going to look for marrow edema. You're going to look for paraspinal edema to clue you into a fracture rather than the fracture line itself in many cases. The discs, generally speaking, the annulus fibrosus is quite dark on imaging, and the nucleus pulposus is bright. As you see in this example I gave you, the nucleus pulposus are actually quite dark, and that's something that we see in the cervical spine, even in the absence of substantial degenerative changes. Next slide, please. Moving on to the ligamentous structures, this is really where MRI shines. The ligamentous injuries. So ligaments, again, we're talking about water and fat. That's what we derive MRI signal. So if there's no water or fat in ligaments, which is true, then they should be dark, and that's what we expect. So the anterior longitudinal ligament, which I've shown, on that image on the right, is actually is imperceptibly thin. And so really what you see is when you see bright signal coursing through that area, that's how you're able to identify a ligamentous injury. The same thing goes for the posterior longitudinal ligament. It's almost imperceptible from the annulus. It's imperceptible from the posterior margin or the posterior cortex of the vertebral body. But when you do see a disruption there, it'll present as bright signal on a fluid sensitive sequence or on your T2 or on your STIR sequence. Same goes for the interspinous and supraspinous ligaments and the ligamentum flavum. Again, you can see there's dark signal there in those locations, but it's really imperceptibly thin. Next slide, please. Last but not least, is the spinal cord. I joke I'm an MSK radiologist. I don't look at the spinal cord. I look at everything around it. But obviously, the spinal cord is quite is a critical structure evaluated by MRI, and it should be intermediate in signal on a T1. I'm showing you a T2 here. It's pretty bright, right? It's not as bright as the CSF space around it, but it's pretty bright. When you see increased signal within the spinal cord, that could indicate cord edema or cord hemorrhage, and we'll show an example of that. Obviously, the cord is surrounded by the CSF, which is quite bright on T2 and STIR sequences. When you see space-occupying lesions in the epidural space, obviously in the setting of trauma, you're going to think about something like an epidural hematoma. The hematomas themselves can be bright or dark on any one of the sequences I described to you, having to do with the age of the blood products. But nonetheless, their presence and the resulting mass effect on the cord, critical findings of critical clinical importance, are really nicely seen on MRI, and we'll see some examples. Next slide, please.
Hey, Jed, can I just add,
Yeah,
do you
please.
want to talk quickly about like what these lines are and then maybe how to problem solve if they're real or not?
Yeah. So this is a great point. So one of the challenges with imaging the cord is that for a variety of different reasons, you can get artifacts. It's true for all MR. You can get artifacts from the pulsation of CSF, which will create dark lines. It's particularly commonly seen in axial images, the axial T2 images, which are commonly acquired as part of any cervical, thoracic, or lumbar spine exam. You often get these little lines, like right where my arrow for the cord is, you can see a line there. That's often a fake out. That's like a ringing, or it's some sort of pulsation artifact. Essentially, the MRI machine is kind of misunderstanding an edge or signal, or a signal void that's created by another structure. And so those can be fake out. So I think I'll talk about this on another slide, but one of the critical things to do, especially when you're looking at a STIR sequence, which is even more susceptible to these artifacts, is to correlate it with your other sequences, your axial T2 images. And the axial T2 images should really be they're going to be less sensitive for cord abnormality, but they're really going to allow you to determine whether what you're seeing is artifact or not. It's hard to describe all the artifacts. This is one of those things where I like to say you just have to see a lot of them to know when it's artifact or not. But it's actually quite a common location for artifact in the cord. That's a great point. Thank you, Connie.
Sure.
So here's an example of an 18-year-old male who was unrestrained in a motor vehicle accident. The car rolled into a ditch. And on the CT scan, you can quite nicely see that there's a traumatic malalignment at C2-3. The calipers show the degree of traumatic anterolisthesis of 2-on-3. It looks like there's a widening of that C2-3 disc space, so presumably there's a fracture that's either going through the disc itself, or where the Sharpie's fibers are attaching at the anterior and posterior aspects of C2. And there's I think on the CT, you can appreciate that the interspinous ligament between C2 and C3 is widened with respect to the other levels. And so I think those are all findings that are nicely made. I think what you can also see is that traumatic malalignment, that posterior neural arch of C2, is causing spinal canal narrowing. But the degree of spinal canal narrowing and the degree of cord compromise is really not well evaluated. The MRI really beautifully shows all of the ligamentous abnormalities and the implications on the cord. So Connie's pointing out right behind that endotracheal tube, or I guess that's probably an oral airway that's there. You can see that there's a lot of prevertebral edema and hemorrhage. The anterior longitudinal ligament is disrupted right there. Thank you, Connie. So is the posterior longitudinal ligament, which is also disrupted. And moving down the list, right, the ligamentum flavum is disrupted. It looks like it's kind of peeled off of the C3 posterior, the C3 spinous process, and then the interspinous ligament is also disrupted. And the interspinous ligament is kind of hard to see because everything around here is so bright and edematous and full of hemorrhage. But if you look at the C4-5 or C5-6 interspinous ligaments where there's dark signal, that's what it should look like. So there's obvious bright signal, obvious ligamentous injury. And then the implications of this is that there's spinal canal narrowing and compression of the spinal cord. And there's this kind of ill-defined bright signal within the spinal cord, which is probably a combination of a hematoma in the cord and associated edema. So, the CT shows a lot of the critical findings. The MRI really shows the ligamentous injury and then the cord abnormality. Another example here, this is the other end of the spectrum. This is instead of an 18-year-old, now we have an 84-year-old male. The question is, which ligament was injured here? And I think this shows where MRI can really shine in some subtle findings. So there is some edema along the anterior aspect of the base of C2, which is a pretty subtle finding, but that's probably some injury to the anterior longitudinal ligament, right? There's also some linear signal at the base of the dens, which I'll show you on the CT is actually a fracture. And I think I try to use this as an opportunity to illustrate how CT can sometimes be better for looking at fractures than MRI can. But the other important finding that Connie was showing is that there's edema in the region of the interspinous ligament. Again, a subtle finding, you might chalk that up to being a vessel, but in the setting of trauma, that's an interspinous ligament injury. So let's go to the next slide, please. There we go. So, oop,
This
there
one,
we go.
right?
Yeah, that's the one. Yeah. And so just to illustrate, I think we showed those the annotations there showed what we just talked about a moment ago. But the reason I'm showing you the CT is it shows you that fracture. It's actually quite subtle on CT and on MR. I do think it's easier to see on CT. And what I'm trying to illustrate here is MRI is really good for identifying ligamentous structures. I think a big fracture, by the way, is better seen on CT. And some of the more subtle fractures, particularly of the posterior elements, I think can be really challenging to see on MRI. And CT really is the superior modality for that. Next slide, please.
Oops, sorry.
Here's another case here. I think this is my last case, and I'll jump back to you guys. This is a 60-year-old female who had syncope and fell down the stairs. And yeah, there's a C2 fracture. There's all sorts of stuff going on, which I think is important to see. It would certainly be important clinically, but I think what I'm trying to show here is, in this case, you have a T2 weighted image on the left, and actually another T2 weighted image on the right. There's this space occupying structure in the kind of left posterolateral spinal canal. It's bright on T2. It doesn't really matter what the signal characteristics are so much, but in the setting of trauma, that's an epidural hematoma. And what you see is that epidural hematoma is really having substantial impact on the spinal canal and the cord. The cord is displaced laterally to the right. The left side of the cord is displaced anteriorly and compressed. And so I don't have the CT image for this patient, but this was totally occult on CT, no matter how aggressively you window. And that's not uncommon. I've missed hematomas literally from the occiput to the sacrum on CT that are then subsequently seen on MRI. It's very difficult to see these on CT, and that's another opportunity for MR to shine. And obviously, this has implications clinically and in surgical management. Next slide.
All right. Well, I'll give my 2 cents. I want to echo Jad and Connie's thanks for having us, and it's exciting to be talking to a big audience about spine trauma. I'm going to talk a little bit about the classification systems, like how do we take the imaging findings and kind of merge it with our clinical decision making. And so, the most common systems for classifying these injuries are the AO classification and the TLIC, as well as the SLIC or SLIC classification system. And these help take clinical factors and merge them with what we see on imaging to kind of help us categorize these things and make real-time decisions. So next slide. So this is a SLIC or the subaxial injury classification system. And what this does is essentially break things down into 3 categories, which is the neurologic status, what we see clinically with what the patient is presenting with, the morphology of the fracture, which we can usually see on CT scan, and then the discal ligamentous complex, which is essentially what's going on with the disc, the ALL, PLL, and the posterior ligamentous complex, which is the ligamentum flavum, the facet capsule, and the interspinous ligament. And the aggregate of these scores, you can sort of move the slide forward here. The aggregate of these scores help you figure out, what you should do about it. And scores of 3 or fewer are non-surgical management. Either patients have a stable injury that can be monitored, or 4 is indeterminate, which you have to kind of use your judgment to figure out what is going to be the best option for the patient. And then 5 or higher tends to either point to a significant neurologic or ongoing neurologic issue, or in the setting of trauma, or a very unstable injury that would benefit from surgical stabilization. So the next one. Um, so is this
Well, this was sort of the two extremes. So this was
right? Okay, gotcha. Yeah. So this is a 87-year-old male who has a sort of a minor compression related injury in the cervical spine with an intact disco-ligamentous complex. And so this is a very obvious one, which tends to point to non-surgical treatment. We would probably either give this patient a hard cervical brace and for a few weeks and monitor them as an outpatient. And then the next image is the other end of
Sorry,
this.
Stefan, can I just
Oh
mention
yeah,
one
sorry. Go
thing?
ahead. Yep.
So Jad showed some great places where I thought it was easier to see on the CT. I think that's generally true, but when they're this osteoporotic, sometimes it can be really hard to see the fracture on CT, and then it's actually easier to detect the bone marrow edema. Like we're not actually really seeing the fracture; it's just sort of the result of the fracture on the MRI. So sometimes actually the two techniques are really complementary. So just wanted to point that out.
Yeah,
Yeah, that's a
absolutely.
great point. Totally agree.
The other thing I would say, I guess, also, we kind of depend on the MRI, or classically depend on the MRI for assessing disco-ligamentous complex. So, in this patient, it's not totally necessary. But I wanted to echo one thing that Jad said, which was that in a lot of, even here in the U.S., in our tertiary academic centers, we're lucky to have MR imaging all the time, but that's really not the case even in our community hospitals. And so many of the injuries that we see can be seen, or you can see signs of it on the CT scan. So the sort of process that Connie took us through of looking at the alignment of the facet joints, the spinous processes, the alignment of the vertebral bodies, the size of it from C2 down to T1. All of those are important, and oftentimes you can see facet splaying or interspinous splaying, or signs that there may be ligamentous injury on the CT scan alone. And sometimes, if it's from a logistics standpoint, it's not easy to get the MRI on a frequent basis, both in the US and maybe abroad in other resource limited settings. You have to make a decision based on what you see on the CT scan. So that's the other thing to keep in mind as you kind of assess the CTs and MRIs of these cases. But yeah, so we can look at the other end of the spectrum here on the next slide. So this patient, and Jad showed this as well, but this patient had an incomplete cord injury with ongoing compromise, which essentially means, the patient has some neurologic function, but has loss as well. And you can see active cord compression. So that's the highest score you can get for that category in that classification system. And you'll notice even in that injury class, I should have pointed to it when we had that slide. A complete spinal cord injury is worth 2 points, whereas an incomplete cord injury is worth 4 points, which essentially is framed that way because patients with incomplete cord injuries have a higher risk of progression. You have more to lose, so to speak, as opposed to a complete cord injury where the chance of getting improvement, even with intervention, tends to be much lower. So an incomplete cord injury tends to sway the scoring system towards a surgical intervention as opposed to a complete cord injury. So that's one thing to note, and it's kind of the same in the TLIC as well, although less so than the cervical spine. So this patient had a very obvious surgical management. He had incomplete cord injury with ongoing compression, distraction morphology. You can see that the 2-3 joint and the 2-3 facet is distracted and dislocated posteriorly. And then the disc and the ligaments are disrupted for it to be able to do that from an alignment standpoint. And so that's a very obvious surgical 9, which is one of the highest scores you can get for this type of injury.
What do we want to do about time? Because we're supposed to end at 8:45, but we still have some
Oh,
more spine
yeah.
is left.
I think keep going, Connie. I
Keep
think
going.
this is a great presentation. I'm learning so much.
All
Yeah.
right, Jad,
No,
do you want to
but
take this?
we just as
Okay.
a heads up, we do have a few questions from the audience that have been peppered throughout, like related to Jad and your talk, and I'm sure we'll get some from Sapan. So just keep that in mind. I'd love to answer these questions too.
Okay. All right. Then
Great.
maybe Jad start going and we'll just go faster.
Okay, I can go fast. Connie knows I speak a lot and talk quickly, and that's a bad combination.
No,
Um,
don't speak too fast.
and don't speak too much. Yeah.
No,
Well,
don't speak too fast. We got people from all around the world. They want to hear and understand what you're saying. So take your time.
okay. Thank you. Um, we're moving now to the lumbar spine, and from an MR perspective, and from an anatomical perspective, there's a lot of similarity in the thoracic and lumbar spine in terms of the marrow signal, the disc, vertebral body anatomy. So we'll focus primarily on the lumbar spine. I think the examples we give are of the lumbar spine. This shows what I showed you before, which is the normal marrow signal in the lumbar spine. So that, again, as a reminder, the marrow is normally bright. It's actually brighter in the lumbar spine than it is in the cervical spine, owing to the fact that there tends to be more fatty marrow in the lumbar spine than in the cervical spine. And so it's going to be bright on a T1. It's going to be bright on a T2 for the same reason, because the T2 weighted sequence is actually a one where fat is also bright. And then on that fluid sensitive sequence on the right, which you could either see as a T2 fat set or a stir sequence, again, for our purposes are the same. Everything is dark except for fluid. So as you see, nicely see CSF space. You nicely see the nucleus pulposus and some vessels in the posterior lumbar region. All right, everything else is dark. As a reminder for the discs, this is relevant, I think, for any spine imaging. It's relevant in the setting of trauma. It's relevant in the setting of degenerative change. It's just a reminder of what the disc should look like. So the normal disc is really confined to the ring apophysis, right? That peripheral ring at the superior and inferior end plates, and shouldn't extend beyond that. The annulus fibrosus is dark. The nucleus pulposus is bright. On our fluid sequences, our T2 and our stir. You can get a little line through the nucleus pulposus, which is kind of a little trick I always play on our residents when I ask them if that's normal or abnormal. It's actually normal, but it's also abnormal. It tends to develop in the third decade of life, which probably means most of you have it. And so it is actually some degree of degeneration, but since we all get it, we like to call it normal, so we feel better about ourselves. But these are normal looking discs, essentially. Next slide, please. I'm going to go quickly here because I think it is helpful to look at these structures in the axial plane. And on MR, it's really amazing how you do see all of these important neural structures quite nicely. So you have the facet joints that kind of outline the posterior part of the spinal canal, including the ligamentum flavum, which is that uniform low signal structure. Lateral to those, you have, or between those, you have the posterior epidural fat, which will be bright, just like the CSF is bright, but not quite as bright. And then the foramina also contain fat or epiradicular fat, and you can see those foramina are essentially wide open in this normal case. And then you can really nicely see the cauda equina nerve roots, which are, because we're doing an axial slice, they look like little dots. And you have the majority of the cauda equina, which is central and posterior. And then you have the nerves that are exiting at the next level through the next foramina. So if this is the L3-4 disc, the L4 nerves, or the L3 nerves is where Connie's pointing her mouse. And then in the subarticular zone, or in the lateral recess, you can see the L4 nerves that are preparing to exit at the level below. So really beautifully see all of these structures on MRI. Next slide. So let's move on to some trauma. All the rules that we talked about with the C-spine apply: the presence of bone marrow edema, the appearance of our ligamentous structures as dark lines. So same deal here with these with the anatomy in the lumbar spine. In this case, this is a 23-year-old. Like I said, a lot of skiing related injuries in the C, T, and L spine in our area. And sure enough, this is a 23-year-old who fell 60 feet or 18 meters off of a cliff while skiing. And what you see at L2 is that there's loss of vertebral body height. Looks like there's a irregularity at the superior end plate suggesting a fracture. The AP view shows it as well. Um, you can nicely see that. What you can't see on that radiograph is the degree of bony retropulsion, whether there's any compromise of the spinal canal. On this CT image, you have axial and coronal images, which really nicely delineate this fracture. And you see a large retropulsed fragment from the posterior superior aspect of the vertebral body that's causing spinal canal stenosis. You can see from this axial loading force that caused this injury, you can imagine that there's going to be distraction of fracture fragments anteriorly and posteriorly, which is exactly what happened here. The axial image through there shows that there's a large bone fragment that's extending into the spinal canal, and there's really very little spinal canal left there. So this is a severe stenosis. And surprisingly, in this 23-year-old, this patient was neurologically intact on exam. So let's look at what MRI shows us here. So again, this is the same patient. And what you see is there's some bone marrow edema on the image on the left. That's a STIR or T2 weighted sequence. Again, doesn't matter. But you see the marrow edema, the bright signal in that L2 vertebral body, which is indicating edema and hemorrhage in the marrow space. The middle image is a T1 weighted sequence. And the line is manifest as a dark signal. So you can see that dark line extending through there. What you'll probably notice is that the actual fracture lines or the fracture morphology is harder to see on the MRI than the CT we showed before, and that goes back to the point we said before. CT really nicely sees cortical and trabecular bone. It's a higher resolution exam, so it can really nicely see that better than MR. What the MR shows you nicely is that retropulsed bone fragment, and it shows you the fact that there's a compression of the cauda equina nerve roots as a result of the stenosis. What's interesting here is this, again, we're talking about the ligaments. The anterior longitudinal ligament is intact. The posterior longitudinal ligament is actually intact. It's kind of bowed and stretched, but there's no bright signal discontinuity in that posterior longitudinal ligament. The ligamentum flavum and the interspinous and supraspinous ligaments are also intact.
I was going to say, I think this is a young person.
Yeah.
So they have well-hydrated ligaments. So I mean, I think it's incredible. I think that's probably why neurologically he was okay, because that thing is just still holding the
Yeah.
fragment in.
I
So
would have broken it. I would have broken it in half here for sure. So nice pliable ligament. So here's the axial images that show this really nicely. And there you see, once you get that image right there, so you have that bone fragment that's in the ventral epidural space. It's compressing the cauda equina nerve roots. There's no CSF space, right? Connie, can you go back a couple slices? So those are happy cauda equina nerve roots floating around in CSF space. And as you go back up to that fracture, that whole space is totally obliterated. That's a severe stenosis. And so that's again, shows really the strength of MRI in characterizing these injuries and the neurological consequences, or the consequences on the cord or cauda equina.
stop on, you wanna?
Yeah, so we can move through this quickly again. So this is a sort of going back to the TLIC system, which is the thoracolumbar, the analogous system to the SLIC system for the thoracolumbar spine. And so again, fracture morphology increasing in instability causes more points. Same thing for the posterior ligamentous complex. More points if it's injured, which points to more instability. And then neurologic status. Again, when there's spinal cord or in the thoracic spine or conus at the thoracolumbar junction injury, an incomplete injury is worth more points than a complete injury, which just points to more surgical urgency. And so again, the nice thing about both of these systems is that it's simple. You just really have to remember 4 points. That's sort of the inflection point of like non-surgical to surgical treatment. And so it's very reproducible in terms of its application. So in this burst fracture, the patient has a burst fracture, which is 2 points, intact posterior ligamentous complex, which the MRI helps us confirm. This is one of those situations where I would, given the mechanism and the how severe that burst fracture looks, I would be very suspicious that there might be a ligamentous injury, but the MRI helps us feel a bit better about that. And then completely neurologically intact. So we would definitely give this patient a chance to heal this non-operatively. But looks like they got a posterior decompression a month later, and that's probably because maybe they stopped being able to tolerate the degree of stenosis that was there, and that's again just because you treat something initially non-surgically doesn't mean you can stop following them. So I think it's reasonable if the patient's neurologically intact with the intact posterior ligamentous complex to treat this initially non-surgically, and unfortunately they required surgery down the road.
Let me go through the imaging findings real quick for this first.
Yeah.
Yeah, so okay, so this is actually a trauma series because you can see it's actually a chest, abdomen, and pelvis and a reconstruction. So on the coronal images, we can see here's the spinal coming down, column coming down, and then there's an immediate step to the right, and it comes down further, right? So this is severely fractured, and in order to do this, it has to go through all three columns. You can't accomplish this without a severely displaced fracture, and then you can confirm the same thing happens. Like it looks like it's skipping here, but it's not. It's actually because of this step off, and this fractures through the vertebral bodies and the posterior elements. And then, Jad, you want to just talk about the MR? Okay, or I can do
You
it.
got
So,
it, Connie.
all right, so as you're coming down, very similar. I'm going quickly. Sorry, guys, because we're running out of time. But you can see that, okay, so here I'm above the level of the fracture. So somewhere here, right? So you see coming down. Now they're starting to see that the cord is a little bit abnormal. You're starting to see the like that distraction and the displacement. And then as we're coming out of the fracture, like now we're below it, you can see that the white matter in the cord is all bright. So that is a reflection of the fact that the cord is injured at the level of that distracted fracture. And then there's hemorrhage, hematoma, swelling all around the fracture. And then also, just as a reminder, this person also had a C2 fracture. So if you see this, don't forget to look all around because there may be additional injuries. All right, Satman, back to you.
Yeah, and you can I think you can add up the points or you can just see how significant of an injury that is. But obviously they have a 9, and that's a surgical case. A very, very unstable fracture, like you mentioned, goes through all three columns, and actually in that area of the spine, the sternum actually gives a bit of stability as well. So the fact that it went through all of those, they call that the fourth column in the upper thoracic spine, goes through all of that means this is a very unstable injury. So the patient appropriately got an immediate, decompression, hopefully realignment and arthrodesis, and maybe they got some function back if they're lucky.
Okay, should we go to the questions?
Yes, please, Connie.
Yes,
Okay.
first, we'd like to invite Dr. Mengesha to please ask a question, which was asked in the chat, but if we could, please.
Mengistu, are you there? We'd love for you to just ask your questions. He may be
Exam?
running. Hey,
Yeah.
Mengistu, there you are. Go ahead, please.
Yeah, thank you very much. It was really nice. It summarized everything and it information as you mentioned, Kira. So I'm orthopedic spine surgeon working in resource setup and getting the both MRI and CT is not easy. I hope it is the same in most African countries as well as Asian country. Even I was in India for my fellowship and in a government institution. It's not really easy to get both CT and MRI at a time. So in the setup where getting both imaging is not easy, you recommend? Do you prefer the CT scan so that you see the bone? You don't have a good idea about the spinal cord or the cord as well as the ligamentous injury. Then the procedure is operative management, or you prefer MRI if it is a missed choice. That was one of my questions. Regarding to use of the mixed system, of course, in the center where I did my spine fellowship, we use AO classification rather than click. Of course, both give almost the same entity. So, which one do you prefer? I know it is different from country, surgeon to surgeon, and the like. My point will be which one is really more reproducible? Is that the AO classification or the click? At the same time, for the click system again, in the absence of MRI, can we use CT scan as an indirect sign for PLC injury, or during MRI we can't use the click? That's the recommendation. What did you recommend? That's where my point. Thank you very much.
Thanks, Mengistu. Were you guys able to hear Mengistu? The sound was a little bit poor quality,
Yeah.
but if you guys,
I can take a little bit of this and then maybe you guys can chime in. So for in my opinion, I think for trauma purposes, CT is the most important modality. I think number one, it's much more obviously we can see some fractures that are not obvious on CT scan in patients with osteoporosis, but otherwise CT is very, very good at picking up most spine trauma. In terms of like you can also gather a lot of information about alignment changes and ligamentous structures more from an inference standpoint. I mean, our radiologists are probably much more talented at being able to tell where maybe there's some soft tissue injury on a CT scan compared to me. But I can usually tell when there's some, facet asymmetry or there's spinous process widening, and you can get an idea of what's happening from a ligamentous standpoint with a CT scan. So, we would rarely in the trauma setting ever get an MRI without having CT scan information. CT is much more helpful both from an information standpoint and a logistics standpoint. It's a quick scan that can be done on an urgent basis. So from that standpoint, that would be my 2 cents on that. And then as far as TLIC is concerned, kind of going along the same line, I think you can use TLIC even if you don't have an MRI. There are certain injuries that automatically put you into so the neurologic status and the morphology of the fracture should help you get most of it in place. And then there is some, either whether you see the posterior ligamentous injury on CT scan or you infer it, you can kind of play out the scores both ways and figure out whether it really changed. There's only a few instances where like these are borderline, and in those situations, you can use your judgment based on morphology or just get MRI in those very few instances where they're borderline, as opposed to, getting MRI on everybody. If someone's clearly surgical or clearly non-surgical, you can not get the MRI in a resource limited setting.
Yeah, I was going to say the same thing in a slightly different way, but it's like, you're not going to miss the people who are 9, 10, like on the scoring system. You're going to miss those high numbers, so CT is going to catch all those. What MR helps with is when you're in that 4 region. Is it a 3? Is it a 4? Is it a 5? And probably for a lot of those people, if you do try to like stable, with a collar or something like you stabilize them and give them a trial with conservative management and see how they do, and then maybe repeat imaging or just check them clinically, you can kind of, you'll have to use your clinical judgment. Basically, I think if you don't have the MR, you just use more clinical judgment to judge that 3 to 6, 5 or 6 range. And CT will help you to catch and evaluate those really severe ones. Is that so basically a different way of saying what you're saying?
I think that
I'm
was
gonna.
no,
Oh, go
sorry,
ahead.
go ahead, Jed.
I was gonna say I'm gonna go way out of my lane here, and I'm gonna say that I suspect the CT is going to be pretty crucial from a surgical planning perspective to be able to see the bony anatomy, especially if you're going to fuse or decompress. So even if you just had an MRI, I imagine a CT would be quite helpful. Um, so I would think that that's also a consideration as well. But agree with everything that anyone else said. Everyone else said. Thank you.
There was a question. I'd love Jad and Connie to weigh in on this about like using ultrasound. Is ultrasound useful at all in these contexts for looking at ligamentous injury?
Well, the problem is if you're looking at the anterior structures, you're not going to see them all. Some of the posterior structures, you'd be surprised how deep they are, actually. Because Jad and I both do cervical facet injections, and and when you come from posterior, it is shocking how deep those structures are. They're really in the center of your neck, right? So like if you think about that depth, I've buried like a 3.5 inch needle in the entire neck. And plus there are a lot of ultrasound doesn't penetrate those thick ligamentous fibrous structures really well, because the sound beams just don't penetrate those types of tissues. So, but what it is good for is that the nerve roots, as they exit the foramina, on an average person, are actually quite superficial. So if you come from anterior and you're looking, say, for like a nerve root avulsion, you can actually see it quite well. So it could be helpful for some of those things. The problem is if you don't see the nerve root, is it actually avulsed or you're just not seeing it? That becomes tough. But if you do see it, you see it nicely coming out of the foramina, then you could rule out a nerve root injury.
It
Go
sounds
ahead.
like more in the
Yeah,
spectrum of like plexus injuries and that sort of thing, right? Like
Yeah,
then you
yeah.
yeah,
also have the physical exam that you can correlate with, I guess. But super useful to know that it's for these resource limited settings, trying to balance what's available and make use of what you have, to clinically diagnose the patient. I think it's these borderline cases that are so tough, Connie. So really do appreciate your thoughts on that. That's great.
yeah. I
Yeah,
was going to
Peter.
say,
Oh, sorry, go
I
ahead.
was going to say, quickly, ultrasound is a beautiful modality for looking at peripheral nerves, which I know is not our subject today. And that goes up as far as the brachial plexus, but beyond there, it's hard. Keep in mind, ultrasound sound waves don't penetrate cortical bone. So you're only going to see what is on the surface. And that helps if you're looking for a subtle fracture, particularly in like a limb or a rib or something like that. But once you start getting to deep structures in the spine, even in the cervical spine, it becomes very difficult. And that's true in our patients who have more soft tissue than most in the United States, but I think it's true everywhere. So limited use in the spine, but of more utility for peripheral nerve injury.
Thanks, Chad. If
Thank
everybody's
you.
okay, we have so many great questions. I'm going to let Peter ask a few of them. And can we stay on for a few more minutes? Is that okay, guys?
Sure.
Okay, we'll
Sure.
just keep going until 9:10. Go ahead, Peter.
Very much appreciated. So, another question that came through from the chat was one about injury-related factors and timing for MRI. Do you ever let some time interval pass in the setting of hematoma or something else uh, to increase sensitivity for MRI findings?
Um, I don't think there's any change in sensitivity with MR. It's possible that MR becomes less sensitive for looking for fractures after several days or weeks after the bone marrow edema from a fracture starts to decrease. But I think in terms of the looking for a hematoma, I don't think it would be impacted by the time that you do the MR. Quite honestly, often the timing of the MR has more to do with the patient's clinical status, their ability to tolerate, in some cases, a 30 or 40-minute exam to sit, in a coil, right? That they have to be their head has and neck have to be placed in a coil for some imaging, especially if you're doing brain imaging along with it. And so that's often the primary factor that dictates when the MRI happens. But um, some of these injuries may become less conspicuous just over time as that hemorrhage, those secondary findings go away. But in terms of the sensitivity, I don't think it really substantially changes it.
Agree.
Thank you. And then we had another one regarding the SLICS score system. Um, Somebody wanted clarification on how you can tell ongoing cord compression.
Oh yeah, I think Sapan answered it in the
Yeah,
chat. It is
it's just
determined.
that only really matters when the patient has a neurologic deficit, but when they do, and you see ongoing spinal cord pressure, mechanical pressure, or structural pressure on the MRI, that's how you get that extra point on the slicks.
All right. Just to get back to it and sum things up, I think uh that's it for the questions that we got at least through the chat. Thank you again to all the presenters and everybody that attended on this Saturday, whether it's morning or afternoon or evening, wherever you are
Peter,
around the world.
do you mind if we just take a moment for the three faculty to give their like final like little closing teaching points for the audience here? Because I think we had a really great engaged group with some awesome questions, particularly for the resource limited setting. I think the advice, maybe we could start with Jad on that one about like what he's seen go on in Kigali and some advice for our young practitioners on the line.
You know, thank you. I've spent a little time over several years in Kigali at CHUK, working with the radiologists there and interfacing with some of the members of the trauma team. Um, and it's a relationship that I really value. Um, I saw some really incredible trauma cases, head and neck trauma, cervical spine trauma, um, primarily from motor vehicle and scooter accidents. And I was always really impressed by the work that they were doing there. I think most of their triage and management was determined based on CT, and so I think that really underscores the importance of CT in these situations. What I'm Connie can tell you, I am very biased. I'm the MRI person in our group. I do a lot of MRI operations, and although I'd love to be biased towards MRI, CT really is the modality of choice, and I think we've tried to highlight that during this talk. And then MRI is a very useful problem-solving tool in certain situations, whether they're clinical situations or imaging findings that you come across. Um, so again, thank you so much for your attention and for this invitation. I really appreciate it.
Thanks, Chad. Connie, any final closing thoughts for our practitioners?
Um, Not really. I mean, I think Sapan made some really good points about like, there's a lot of things that you can, if you don't have the resource, then you can infer from alignment. So don't forget to look at alignment and don't forget to I know there are a lot of cases you will miss. That's just a reality of the CT technique compared to MR. But if you really, you should try to look because sometimes you will see it. And, in those cases, then it's great. So always try. Don't forget the soft tissues on the CT.
That's a great teaching point. You can see soft tissues on CT, and so that's really helpful. Thank you. Seplan, as a surgeon, any last comments?
Yeah, I think as a non-radiologist who, probably gets pulled in just when there's a question of something wrong, I felt the best learning was looking at lots and lots of normal CT scans. And over the course of my training, fellowship, and practice, looking at thousands and thousands of normal CT cervical spine kind of tells you how much, 1-2 motion is normal, how much, facet changes you might see. And, at a certain point, you that just looks wrong, and that's the way you figure out. And so I'm sure that is probably the best way for folks with some instruction, but mostly experience to be able to pick up, obviously obvious injuries, but inconspicuous injuries on CT scan. And so most of the time, we're actually not super dependent on MRI to figure out what we need to do. But it helps confirm and make a better decision. So my only advice would be just to look at as many normal CT scans in patients as you can.
Super
Can I
helpful,
add what
Seplan.
can I add one quick point? And it's going to sound maybe obvious. We're much better when we work together. Radiologists are much better when they interface with clinicians when we speak to you. I hope that you are better when you work with us. And so I think that's a really important thing. The things that I've learned as a staff member now for several years, the things that have really taught me have been scenarios where we've worked together with colleagues in orthopedics or neurosurgery um, with regards to the spine. And so that's, I think, a really important piece. Radiologists, contrary to popular belief, we're here to help. And so please like engage your radiologist. I think you'll find that they'll be a useful resource for you, helping with problem solving, helping with tough cases, and sometimes guiding you with what the best imaging modality might be. So thanks again.
What a great note to end on, Jad. Thank you. And all of the folks who are on the line, please, give your radiologist a hug if you guys are surgeons. And if you're a surgeon, if you're a radiologist, give your surgeon a hug. This is great. Thank you. Peter, you want to take us out?
Of course, many hugs again to the faculty presenters, especially the radiologists, but everybody else again, once again for joining us on a Saturday. Um, Reminder that there is a certificate for participation. You can complete course evaluations through the QR code here, and certificates will be handed at the course conclusion. Here's just a reminder once again about next week's AIS case discussion, and then reminder once again that on the 31st, it'll be endoscopic spine surgery on a Sunday. And then plug one more time for Sona, where you can learn lots. And here's a QR code that'll take you there. And you can learn about where more of spine trauma there. Thanks again for joining us today. Any questions and comments can be sent to the email address that's listed on the screen. Many thanks and see you next week.
Thanks so much, Peter. Just if you don't mind leaving that last slide up so people can click the or scan that thing, that'd be awesome. And thank you so much, guys. Really do appreciate the time on a Saturday. We can leave the screen open for a few minutes just to let people click on the links and stuff like that. Thank you all. Have a great Saturday.
Thanks,
Thanks and
guys.
bye.
Bye-bye.
Bye, everybody. Yeah, we'll post this online and we'll let you know once it's posted. Thanks, everybody. Peter, great job hosting. Thank you.
Thanks for letting me get into this. Looking forward to more.
Yeah, awesome. Thanks, Peter. Thanks, everybody. Take care.